complex at Lakeland, Florida, coming to you live from the 2014 Sun and Fun Fly-In. For over 16 years, we have been bringing the aviation safety message to you by seminars, workshops, and videos using our aviation safety team representatives, which means our production crew is made up almost entirely of volunteers giving their time and effort to aviation safety. After today's presentation, if you would take the time to just stop and thank the crew out there, those that are doing this, stage and floor and camera crew, for their time and efforts, I know they would really appreciate the recognition. Our next presenter, I'd like to introduce. He was head of the Medical Specialized Division of the Office of Aerospace Medicine, and now he is serving as our Deputy Federal Air Surgeon. Let's welcome Michael Berry, Dr. Berry.
Oh, it's not going to stay, is it? Stick it in the back pocket. Right there.
I'm sticking it in his back pocket. How's that?
That'll work? Yeah, okay. Wow, bright lights. I think I'm going to stand off here to the side a little bit. I want to thank everybody for coming, and those of you, I guess, that are watching that are not here. We've got a very little intimate group sitting here, and I hope I can tell you something that is new, and what I'm really going to try to do is sort of set the stage and maybe answer some of the questions that you've come here with. And if I don't answer the questions after my talk, certainly open it up to the floor and you can ask the questions as we go through here. This is really what I'm going to talk about. I'm going to talk a little bit about my background and then talk about some safety data, which is really what we're all about. And it's certainly, from an aerospace medicine point of view, what we are about. Give you some statistics and certification data, medical certification data, talk about some of our recent decisions and issues that we are dealing with right now, give a very brief introduction to our HIMSS program, which is alcohol and drugs, and what we try to do to keep individuals with those problems, if we can, keep them in the cockpit or get them back into the cockpit, and then open it up to questions. As far as my background goes, you heard I have been with the FAA for almost 8 years. In November, it will be the end of my seven and a half years, and have just moved up from the manager of the Medical Specialties Division, which is at headquarters, and it's the medical policy division for the FAA. All the medical policy that the Federal Air Surgeon wants disseminated and worked on comes out of that division and goes throughout the rest of the FAA. Prior to coming to the FAA, I spent 25 years as an aviation medical examiner, so which is somewhat unique. I think a lot of the management people within the FAA don't have that kind of background. So I think I bring a different perspective, having been out there in the field as an AME working with pilots on a one-on-one basis. Prior to that, I was, or during part of that same time, I had also been an Air Force flight surgeon, is where I started my aerospace medicine career, and spent time in Spain and in England working with fighter squadrons, and following the Air Force, I got specialty training in aerospace medicine and then went to NASA and was a NASA flight surgeon. And worked with NASA for the first 2 space shuttle flights, helped select astronauts. Oh, it wasn't bright enough before, now it's really bright. And following that is when I went into private practice of aerospace medicine and worked with, that's all right, worked with General Aviation as well as airline pilots, corporate pilots, and that sort of thing. So that's the perspective that I bring to working within the FAA. A month ago, I was moved up to become the, okay, is that a message or what? To become the Deputy Federal Air Surgeon. And Dr. Frazier, who's now the new Federal Air Surgeon, I have worked together for the last almost 8 years now, and so I think we will do fine together for the foreseeable future anyway. So let me move on. This is the organizational chart, which sort of I can talk to sort of show you where various parts of the Office of Aerospace Medicine are. I was sitting with our two docs that are here, and if you've got some really specific questions, I encourage you to go see either Dr. Carter or Dr. Angelisi in our booth here, because if you've got specific questions about your medical case, they can certainly answer it. But one of the questions I got asked as I was standing there yesterday was, I mentioned something about headquarters, and they said, "Oh yeah, Oklahoma City, right?" Well, obviously, I mean that's where you as a pilot interact with, as if that is the headquarters. But obviously, or maybe not obviously, it's not. Headquarters is actually Washington, D.C. Where the rubber meets the road and where all of the initial work is done does happen to be Oklahoma City. Dr. Carter, who's sitting here in the front row, is one of our certification docs at Oklahoma City. If you look on the right-hand column there, under the director of the Civil Aerospace Medical Institute, all of those functions those are all Oklahoma City. So you see the Aerospace Medical Certification Division. That's where your Airman Medical Certification data goes. It goes to them, and if it's a case that you didn't get your medical certificate at the time you saw your AME, that's where your case is being worked. In addition to that, we have the Medical Education Division, and that's for educating pilots as well as our own designees, which are aviation medical examiners. We have approximately 3,400 aviation medical examiners scattered across the country. They are not our employees. They are not FAA employees. They are, as I said, they are designees, but they are the eyes and ears of those of us that actually work for the FAA. We're obviously not touching you. We're not doing your physical exam, but we need somebody that can. And so they act as our eyes and our ears and do the actual physical exam and then give us the information by which to make medical decisions. We have two research areas, the Human Factors Research Division and the Aerospace Medical Research Division, which we utilize, as well as research just throughout the medical community in trying to help us with our policies so that we can stay up to date when we're talking about medicine and the policies that we use to determine what are how do we approach various medical conditions, and is it safe to fly with or is it not safe to fly with. Under the other yellow box there, the Deputy Federal Air Surgeon, all of those various functions come under headquarters at Washington, D.C. Those are all located there. Medical Specialties Division, which I said earlier, is the policy division, which is where I came from. Program Management is simply exactly what it says. The Drug Abatement Division, from a General Aviation point of view, you won't really have anything to do with that, but that is our actual division that interacts with the companies that have aviation as what they do. It's the airlines, it's corporate aviation, it's small mom and pop type 1 or 2 aircraft organizations, and by federal law they have to have a drug testing program. And our Drug Abatement Division is what oversees this to make sure that all of the various aviation companies throughout the country actually do have drug abatement programs, and they do drug testing under DOT, Department of Transportation regulations, and they oversee that and make sure that the reporting is coming to us so that we know what's going on. And then you see what's called the Regional Aerospace Medical Divisions. We have, within aerospace medicine, and depending on the particular line of business within the FAA, we have 9 regions. So we have 9 regional medical offices scattered across the country. The particular one that's in charge of where we are right now is the Southern region, which is out of Atlanta. The biggest region with the most pilots of our 9 regions, as a matter of fact. But there's a regional flight surgeon in charge of each one of those regional offices. And I will throw out now for you that as a pilot, that the regional flight surgeon is a great source of information for you. I know that a lot of times pilots try to call, or not try, they actually call Oklahoma City to try to find out information as to what's happening with their medical, and they don't get a lot of information, depending on who they end up talking to. And you can also utilize your regional flight surgeon in the same manner, and oftentimes get through to somebody that can give you some information. Medical certification is a virtual process, and so even though your information may physically reside on a computer server in Oklahoma City, anybody can look at it within aerospace medicine. And so a regional flight surgeon in New England or California can pull up your case. It's why right now the two docs that we have here are actually can pull up individual cases, and they are working cases right here. All for the last several days they've been doing. They'll continue to do it today. They can pull up your records and look and find out whether what you have sent in is actually been received, if it's there, if somebody else has touched it and looked at it, what kind of review has been done. So I recommend that you keep your regional flight surgeon and that regional office in mind as another source of information if you get frustrated with Oklahoma City. We want to help you. We want to make this process of medical certification as transparent and as flawless as we can. It's a continuing work in progress, and there are numerous things that tend to make for a number of delays that we are not happy with, is no more than you are happy with. So safety data. What I'm really talking about is what we are here for is safety of the national airspace. I mean, that is our job. First and foremost, as an aerospace medicine specialist, as a flight surgeon, is the safety of the national airspace. And I will say that the secondary and as important, and they go hand in glove together, is the philosophy of the Office of Aerospace Medicine. It was the philosophy under Dr. Fred Tilton, who was the previous federal air surgeon. It is the philosophy of us today. It was my philosophy as an AME. When I was an AME and I had a new pilot that would come to see me, one of the first things I would tell them and try to convince them of, and sometimes it took a while, but I would certainly try to emphasize this, that as the AME, it was not my job to ground the pilot. It's not my job to ground you. My job is to work with you, and if at all possible, no matter what your medical condition is, find a way that we can mitigate whatever risk there is from your medical condition and keep you flying. As long as it's safe to do so, that's what my job is to do. And I will work with you as a pilot, I will work with the FAA, and we will get your medical certificate. If we can't, it's because there is no way that it can actually happen. That is our philosophy, and which is what really made me happy, because I came to the FAA with that idea, and that is our philosophy within aerospace medicine, is that we will bend over backwards to make sure that you can fly. If we end up, unfortunately, have to tell you no, you can't, there are valid medical and safety reasons as to why we end up making that decision. So from a safety point of view, what are we talking about? We're talking about aircraft accidents. That's what we really want to prevent. And we certainly want to prevent death. And this is data only looking at general aviation fatal accidents, and this includes, as you can see, general aviation that actually includes all of unscheduled, Part 135, Part 137. So it may be a little bit larger group than what you would normally think of as general aviation. That top number, the top line up there, the black line, are actual deaths that have occurred, and this by year goes down to 1989 up through the current time. 450 deaths so far. That was 230. That was for 2013. And you can see in the red and the green. The green is our projections and what we don't want to go below in terms of. Get that out of the way. Can I turn this thing off? Maybe not. And the red is, again, these are total number of accidents, so you're looking at 259, and our goal was to be 257. So that's what we're here about, and I think you, as a pilot, would certainly agree that you certainly don't want to be part of an accident, and nor do we want to, and that, from our point of view, that is a failure in the system. If the accident occurs, then there's something we want to see, is there something from the safety management system that we could have done to prevent that. So certification-wise, this is from the AME and you as the pilot up through getting your medical certificate or not getting your medical certificate, and the way the data flows, and how, if you've gotten denied, if you don't like it or don't agree with it, how you can appeal. Everything starts with the aviation medical examiner, and as I already mentioned, it will go to Oklahoma City in the Aerospace Medical Certification Division, and the manager of that division that oversees all of that. If for whatever reason your medical certificate gets deferred and the AME is not allowed or not able to make a medical decision, then it will go to the certification division, which they may or may not give you a medical certificate. If they say denied your medical certificate, it may at that point get referred up for action at the Federal Air Surgeons level in headquarters. We have doctors there within the medical specialties division that will look at it, or you can actually appeal your denial of your medical certificate to the Federal Air Surgeons level. It doesn't become a final denial until it's reviewed at that level. If the Federal Air Surgeon decides, no, this is a risk that is definitely something that we can't give you a medical certificate, at that point, and you get a Federal Air Surgeons level denial, you as a pilot have the opportunity to appeal that decision to the National Transportation Safety Board. It is a hearing, somewhat like a trial. It's like a courtroom, not exactly, although with recent decisions, recent things that have happened in Congress, which I'll talk about in a minute, something called the Pilot's Bill of Rights, what used to be a very relaxed type of atmosphere where you could almost navigate the process without a lawyer, you as the pilot navigate the process without a lawyer, where the administrative law judge that runs an NTSB hearing would actually work with you even if you were not represented by counsel. And it was a much more, I will say congenial, it was a much more easy process. With the Pilot's Bill of Rights, it has become extremely complicated, and it's almost impossible to navigate from the pilot's point of view without counsel being present. So that particular appeal process has gotten a little bit more difficult with the Pilot's Bill of Rights. But it is a hearing, and the administrative law judge will make a decision and either uphold what the agency, meaning the FAA, has decided, or they can find for you as the appellant. At which point, either side, meaning if the FAA decided they felt like they had a good case and the administrative law judge did not really do a good job, they can appeal that decision to the whole board, or vice versa. If you were denied and the administrative law judge found for the agency, you can appeal that to the full board. And it's a review of all of the testimony. And it's not a retry of the system, but it's a review of the entire testimony, and both sides end up making a statement in front of the board. That's not the end of the line. You still, at that point, can go to, as the block diagram shows there, you can actually appeal to the Court of Appeals. I've actually had several cases that I was involved with as an aviation medical examiner that did go to the U.S. Court of Appeals. The Pilot's Bill of Rights that I've mentioned has thrown a new wrinkle into the thing, and that after the full board has either the administrative law judge has made a decision and the full board has weighed in, if they get pulled into it, you as the airman also has the option to take it to U.S. District Court. That is something that is new, that was put in as part of the Pilot's Bill of Rights, but you can't go there without going through the entire process to begin with. The U.S. District Court will be somewhat different. It's not a panel of judges like the Court of Appeals happens to be. It will most likely only be what's called a bench trial in front of a judge, and it probably will not be, although it hasn't happened yet because it's all brand new. We've never yet had anything that's gone to a jury trial. Those kinds of things have actually only gone to a hearing in front of the judge itself, and the judge will make a decision. The Court of Appeals obviously the next step would be you go to the Supreme Court. I am not aware of any, at least not anything that I've been involved with, that a case has ever gone to the Supreme Court. Numerous cases have gone to the Court of Appeals, however. In fact, I've had one that I was dealt with personally. That will continue. You may have been notified of your pilot's Bill of Rights 4 or 5 different times, both electronically and actually in paper. And as I said already, the appeal to the U.S. District Court is one of the things. The other thing that has happened as part of the pilot's Bill of Rights in Section 4, the very last section of the law, you can Google it and look it up if you're interested, is in Section 4, this particular law called for a review by the GAO, the Government Accountability Office, Comptroller General, to look at medical certification within the FAA and do an audit of it to determine whether what we were doing within the Office of Aerospace Medicine was valid, were we using current medical practice standards, basically to look at it from top to bottom and make recommendations. That has been completed. They took a little bit over a year to do that. And the draft report is out right now. We're expecting the final report to probably be out in sometime in May. Then the administrator of the FAA has approximately a year to answer whatever the recommendations are from that particular report. They did a very, very thorough job. It's a complicated process, as you can well imagine. And to be able to have people that are not intimately involved with it come in from the outside and try to get a valid, realistic look at it and understand it, I think is quite a job and process. Having participated in that,
Just curious, who are those people that look? They're outside the Office of Certification.
Oh, they have, that's right, and they're not physicians. They are people that work for, and they're a government auditing agency, the GAO is, and they look at all kinds of different other agencies for the U.S. government. And just happened to be that they looked at the FAA Office of Aerospace Medicine. They utilized subject matter experts that they went through from the National Academy of Sciences and were steered toward individuals within this country that were not FAA but had aerospace medicine background, and so they went to doctors within the airlines, they went to doctors in private practice that were aerospace medicine. They even went outside of the country to other certificating authorities, the CAA, which is the FAA for England, the UK CAA, they went to Australia, they went to Singapore, some of the big other certifying agencies to as far as what they knew about the FAA, to give them help and comments on the way that we did things and was it valid or was it not. So we think they did their homework well, and we are hoping obviously that if they can give us some pointers on how we can do things better, we'll certainly look forward to that. And medical certificates. And you can see across the board class 1s, 2s, and 3s. Lots of class 1s, but certainly not an insignificant number of class 3s for those of you that are GA type pilots. And that's across the board as far as that goes. So what's this thing about denials? And those are ones where not only did you get your medical certificate deferred by your AME, but in the long run it was actually denied because you had a medical problem that we felt was not safe. A lot of times we feel it's not safe because we don't have enough information to make a decision. And as you can see there on this slide, if you will actually work with us and supply us with the information that we require, or get the extra testing that is required, the total number of denials drops remarkably. Unfortunately, there are a large number, as you can see there, 3,000 that actually just fail to pursue. Either they don't want to spend the time, it's too complicated, or it's too expensive, and so they don't pursue it and do not work towards getting their medical certificate. But obviously, you know, less than 0.1% is a very small number if you give everything that we're looking for. So if you are deferred because you have a medical issue that the AME cannot do something with, cannot go ahead and give you your medical certificate, and let me say right here, 90% of all of those applications, those 380 some odd thousand at the beginning, 90% of those people will get their medical certificate and walk out from the AME and will walk out very happy at the time of their physical examination. The 10% are the ones that deniably are unhappy. They didn't get it at the time that they saw their AME, and it may take them, depending on the issue, 30, 60, 90, whatever, more days to try to navigate this, as is commonly, I think, referred to, the black hole that is the FAA in terms of special issuance medical certification. We are trying to, as much as possible, shine a great deal of light into that black hole, and would prefer not to have that moniker put on it, but I can understand if you're coming from the outside why you would feel that way. But the special issuance process is, and you can see, again, not insignificant numbers that we are dealing with, both class 1s, 2s, or 3s from a medical certificate point of view. And those are a variety of different medical conditions, which I'll show you what some of them are. Some you may think, yeah, that ought to be, and other ones you may say, gee, my doc says I'm okay, why do I have to have a special issuance? This is sort of lumping everything into categories to try to keep it simple. At the top, that's everything that's cardiovascular. That's if you've had cardiac disease, or coronary artery disease, and you had a stent put in, and you're on a special issuance for that, that falls in there. If you've got atrial fibrillation, you're being treated for that, that falls in there. Anything that has to do with the heart that requires a special issuance, that's 6,000. That's the big number, as one might guess. The diabetes is anything from orally treated medication treating diabetes all the way up through insulin. The only people that can take insulin and receive a medical certificate in our country are the Class 3 medicals, Class 2s and Class 1s. We are concerned about hypoglycemia to the point that at least we have not found anybody yet. We will look at the data, but we have not found anybody that we feel is an acceptable risk that we would certify from a Class 1 or a Class 2. So, and again, a fairly large number if you're looking at the 4,500 there for diabetes. Cancer, it runs the gamut in cancer. We're talking cancer of any organ you could think of, whether you're talking skin cancer, whether you're talking lung cancer, whether you're talking liver cancer, prostate cancer, testicular cancer, you name it. The only one I'd probably say is a metastatic brain cancer would not be one that would be in that group. But that's all the various cancers, and again, not an insignificant number. And it and if you look at what comes under those, both substance use and the serotonin, selective serotonin reuptake inhibitors, the SSRIs, that's an antidepressant medication, things like Prozac that you've heard about. Those are those things. Those are all psychiatric, but that's not included in that 850 number that you see up there. Those are things like depression that was treated and is resolved and you're doing fine, a time-limited anxiety disorder, PTSD, other things like that that are in remission and we feel are at good possibility of not recurring and you're doing well now. Those would be special issuances for that. And that accounts for that 850 some odd. Substance use is substance dependence or substance abuse. A substance use disorder, if one looks at the current nomenclature within that diagnostic categories today, within medicine, seems like everything's getting put on a spectrum. There isn't any one point that you say the diagnosis is this particular thing. It's like with autism. It's an autism spectrum disorder. We now have a substance use spectrum disorder. Within the federal regulations, the two things, because of when these regulations were written, we have substance dependence, and that can be either alcohol or drugs, and we have substance abuse, and again, that can be either alcohol or drugs. Depending on the circumstances related to both, they are medically disqualifying, but if one is in recovery or in remission and good recovery, then you can receive a medical certificate. And you can see what the numbers, the abuse numbers count for more of that 795 than do the dependence numbers. If you've got substance dependence, you're going to be on a special issuance for a fairly long time. The National Transportation Safety Board is telling us that we should never regular issue somebody with dependence because dependence is a lifelong disease. It doesn't go away. If you've got dependence, it's always there. It's like cancer. You may be a cancer survivor, but cancer was still the diagnosis. And so the fact that you're in good recovery doesn't mean that it can't relapse and come back. And so whether we go that route or not, it's still we're still working with the NTSB and our legal counsels as to what's possible. Right now, if you've been special issued in good recovery for substance dependence, alcoholism, or drug dependence, you can, after 3 to 5 years, actually get a regular issuance medical certificate after that point in time. You still have to remain abstinent for the rest of your flying career. One drink is a relapse, and the whole process will start over again. If you've had multiple relapses, can you still get a medical certificate? The answer is yes, which is part of what I showed on the initial slide, is our HIMSS program, and I'll talk to you a little bit about that, just so that you're aware. Substance dependence is not a kiss of death. It's not you're going to lose your medical certificate and your flying career is over. It is possible to get it back. Neurologic conditions, those are things like stroke and a variety of neurologic diseases. smaller number, and transplants. Interestingly enough, we got a pilot came up yesterday and was talking to us about, you know, can you actually get a medical certificate after having had a transplant? The answer is yes. You know, today we're talking liver transplants, kidney transplants, lung transplants, even heart transplants. That's probably the newest one in the transplant category that we have actually certificated. It's a difficult process. We don't have a lot. We've had, I think the highest number at any one point in time had been 6 people that have had a heart transplant, and we have to see those. Those are only evaluated at the headquarters level, not at the Oklahoma City level. I think the current thing, the number today actually happens to be 2. Sometimes they drop out. They don't want to continue doing the follow-up stuff that is required for that. So the numbers vary, but it is certainly something that if you are doing well, even with a cardiac transplant, you can become certificated. So what are some of the things that have happened recently that have had a major effect on medical certification? And if you happen to be somebody with a special issuance type condition, why things may be delayed and why you're hearing that it takes forever to get your special issuance. And obviously the only solution is to quit having to get a medical certificate at all, which we'll talk about in a little. We had one thing, you see this DIWS, that's the acronym, and it has to do with our computer system. As I said, we have a virtual system, and that's the computer system that holds all of our medical data in Oklahoma City. And we went to a web-based program as opposed to a server-based program, and that was about a year ago. It was a good idea. Like anything, it was billed to be it was going to be a lot smoother than it turned out to be. Not quite like Obamacare, but I think we had some of our own glitches within the system. And unfortunately, during that same time all that was going on, we ended up with the government furlough and the shutdown, which slowed things down. And so we had a great drop in productivity within Oklahoma City due to our DIWS web deployment and transfer over to that system, and as well as then trying to catch up from 2 weeks of total shutdown where we were not allowed to do anything. And so we ended up with a giant backlog. There's always a backlog of sorts depending on how many cases come in at one particular time, but it wasn't something that was totally insurmountable. And so what we ended up with, I mean, as you can imagine, you end up with, because of these 2 top bullets up there, you end up with a backlog. And even if you get everything back to working normal, you've still got this other thing. And so you either have to find a way to increase production, not just get back to normal, but actually increase production and output to get rid of that, to at least get back to where you started. We're doing a number of things to try to fix that. And Dr. Carter here is certainly in the middle of coming up with ways to do it. We're having surges where everybody drops everything else, and every particular body within the system is working on one thing to get things moving. But it's like anything that where you have multiple boxes where different parts of the process is done. You concentrate on one box and you get it cleaned out and there's no more backlog, but what you've done is you've fixed it, you've taken it out of that box and you've put it in another box, and now all of these people have a giant pile that they have to deal with. So it's something that you can't just focus on one portion of the process. You got to focus on all of it, or at various times focus on all of it. So it's not an easy thing to just say do more and do more with less, but it's something that we realize is a problem. We're working on it. We think we have gotten some things done, that it's actually coming, the backlog's coming down, and we hope that will continue. And for your sake, we hope it will continue. One of the things that we did, and this actually got started some time ago, as you can see, we started having discussions on how can we decrease the number of conditions that actually require special issuance. Now, we can't allow, due to regulatory and statutory authority, we can't allow we can't give the authority of giving a special issuance medical certificate to an aviation medical examiner. It's against the law. We are not allowed to do that. And what a special issuance means is it's one that you have a medical condition that says we want to see you more frequently than we would normally do it. If you're a class 3, you're under 40, we're going to see you every 5 years. You've got a medical condition that we would feel more comfortable if we had information about your condition on an annual basis. If that's required, if that's what we think is necessary, safety-wise, the only way that can happen is through a special issuance. We can't say, here's a regular issuance, but come back in a year, because that's a good idea. It doesn't work that way. So you will end up with a special issuance. Or if we say, every 2 years we would like to see this particular test, be it a blood test, be it a cardiac stress test. If we want to see that, that's not part of a normal medical examination, so therefore that requires a special issuance. The only people that can give special issuances are a regional flight surgeon in one of the 9 regions, the manager of the medical certification division in Oklahoma City, or the federal air surgeon. Those are the 3 groups of people. And so the only option we had is, can we safely look at some of the conditions that we currently special issue and say, maybe we can allow the AME to look at the data that's there, look at the treatment records from the treating physician, and if everything looks good, we'll trust the AME to say, we can regular issue. Now, I already talked about, okay, so if it's a class 3 and you're young and we're not going to see you for 5 years, are we comfortable by saying we don't have to have any information on this particular date, on this particular medical condition for 5 years? So we can't look at everything, but there were some things that we felt were possible. So this process started in 2011, and in 2012 we actually came up with a total of 18 conditions that were special issuance, and there were some protocols that were proposed, and those 18 conditions accounted for 15% of all of the SIs. SIs meaning special issuance. These were the things that were proposed, and like I say, they accounted for a large number. You can just sort of quickly read through those. And if they require special issuance, they require touching and a lot of work by both doctors and analysts within the certification division in Oklahoma City. So if we could make this happen through the AMEs, leverage our AMEs, and you can see what they're called up there, is we designated them CACI, C-A-C-I. These are conditions that the AME can issue. That means regular issue, not special issue. And it has worked well. Well, let's see, am I going the right way? This was what happened. So we worked on the initial protocols on how to do this. Turned out to be very complicated, and we kept trying to work them down, make them as simple as possible, worksheets. And so even though the effort started in 2011, it wasn't until 2013 when we actually were able to get them on the street. And the AMEs have them now. We're continuing to educate our AMEs because a lot of them, because it's a new way of doing business, and if they've been an AME for a long time, they're not used to it. They look at like you saw on there, a particular condition, and they think it has to be a special issuance, and it doesn't. So it's an educational process with the AMEs, and there are people that will have a special issuance for a particular condition already. It's now become a CACI condition, and they don't need one. When you go back in to get your certificate, the AME at that point in time can give you a regular issuance, and you no longer have to be on the special issuance. And so if you want to look at that number, at the ones where CACIs exist, you can go online to the FAA AME guide. You can look at it just as well as our AMEs do. It's a public document, and you can see what the list of those conditions are. So if one of those happens to affect you, you can go in proactively and inform before you see your AME and find out what it is that I need to bring in, and you'll no longer have to have a special issuance. Sure. Are we supposed to be here at 9 o'clock to ask your comments? It's going to be in this room. Maybe this lady right here can answer your...
You're okay here? Okay.
As long as you don't mind listening to me, you're fine. These 3 conditions were part of that 18 that we have postponed, and the reason we've postponed them is we have some concern as to how long can we really go without getting any information at all, and that's colon cancer, lymphoma, and leukemia. whether we come up with some subset of those that we think you can actually have a khaki for, we're not sure, but we're still working on those. And in addition to that, we're looking for other conditions that were not part of the original 18. We think this process has a lot of potential for decreasing the workload and still doing it in a safe manner. Safety, as I've said, safety is the big issue. So we've had our analysts look through, again, from a safety management point of view, looking at all the conditions that we special issue for and trying to determine if there are other things that we might be able to leverage our AMEs, let the AMEs do what we expect them to do and do it in a safe manner. Just as an example, this is something, if you're not an AME and you're a pilot, but this is something that the doctors will be trying to fill out. And you can, again, you can look at these, and if you are a pilot with one of the conditions that were on there, and you go in and look in the AME guide, you can go find the worksheet in there that the AME is going to need to follow. And that very first thing up there, it says, okay, treating physician finds the condition stable on the current regimen and no changes are recommended. And the kind of things, what's acceptable, you can see about the medications, and what you're going to have to bring in as the pilot. The more you bring in at the time you see your AME, the more likely he's actually going to be able to fill out your medical certificate and give it to you at the time that you were there. As opposed to, oh, well, I don't have this, go back, get your stuff, bring it back, and we'll have an appointment 2 weeks or 3 weeks from now and we'll get it done. So again, I recommend that you be proactive, and hopefully your AME will be able to help you. So what are some of the recent things that have happened? This isn't really recent anymore, but the antidepressant medications I talked about, the SSRIs, it's actually, we're coming up on the 4-year anniversary. It was in 2010 that we, for the very first time, allowed pilots that were taking one of these 4 medications, the fluoxetine at the top, that's the Prozac, and then the other ones are down there, Zoloft, and these are the generic names, not the trade names of those medications. And traditionally, all the time I was in AME, if you had to take one of those medications for your depression, or take it for something other than depression, if you were taking it for pain relief as a pain management adjunctive tool, you weren't going to get medically certified. And so after I came to the FAA, we worked hard and found that we felt this could safely be done as long as it was done with getting some extra information, both from a psychiatric point of view and a psychological point of view. And so we had authorized a process by which this could happen. You can only be on one of the medications, not on multiple medications, and that was because if you were on multiple, it was probably a more severe depression than we wanted to deal with. We were only talking about mild and moderate depression, definitely not severe depression. It would need to be stable. We initially started out, you had to be stable on your medication for 12 months. By experience over the last 4 years, we felt like we can safely do it now and only require 6 months of stability on a single medication. Close monitoring, and that's through what we call a HIMSS AME. HIMSS stands for Human Intervention Motivation Study, which I'm going to talk about. But these are the same AMEs that have been specially trained to follow our substance-dependent and substance abuse pilots that are in recovery. And so they were working already from a psychiatric point of view, so we felt like these AMEs could probably work this process of how to work special issuance for these types of things. You have to get a psychiatric initial evaluation and an ongoing report, because generally most of these are either anxiety or PTSD or depression related people, and a psychologist to get an initial report and some psychological testing. It's just a screening test, a single screening test, and that has to be continuous on an annual basis or every 2 years, depending on the class of medical certificate. So there is a way to do it. The numbers are not big. I think part of the reason the numbers are not big is that there still is a general consensus within pilots that if I'm taking a medication of any kind, it's going to ground me, I can't do it. When I was an AME, the number of pilots that would come in and say, please don't put me on blood pressure medication because I know that if I'm on medication, I can't get a medical certificate. And I'd say, so why do you think that's true? And he said, well, I just assumed that it was. I said, no, you're much better off getting your hypertension, high blood pressure treated and the possibility of having to not get a medical certificate for that is just about zero. I said that, you know, just about every medication that out there on the market today that is commonly used, we can get you a medical certificate. Today, we're not even special issuing. When I first did it, it was special issued. Now it's no longer that case. So I think there's some misunderstanding within the pilot community that they can't be taking any medication. That's not true. But the process is cumbersome, and it is expense related, and that you got to see a psychiatrist, you got to see a psychologist, and get some testing done, and it's got to be done on a repetitive basis. So right now, we've only got 174 cases, and a lot of those have actually gotten certified back at the beginning in 2010, and they're continuing to get certified on either an annual or biannual basis. Dr. Carter.
The question has been asked at Sun and Fun, what if you need to take an SSRI for a non-psychiatric condition? Can you still get a waiver for it, and how does that work?
The answer to that question, to everybody hear it, it's can you do it? Can you get certified for something other than depression? And the answer is yes. We have people that are taking it for irritable bowel syndrome. We have people that are taking it for pain management. We have people that are taking it for menstrual problems. And the answer is yes. If it is taking care of your condition and you don't have serious side effects, the answer is yes. You can do it. So, and we run the gamut. I mean, anxiety is another big one that people are doing it. So the denials you can see are small, and we've still got 35 currently in processing. Obstructive sleep apnea, a big issue that hit the, you know, if you read AvWeb or AOPA News, there was a lot of misinformation that went out about sleep apnea. We have a policy, not a policy, we have a recommendation, guidance to our AMEs that has just gone out. We are still working on it. If you read all the hype that went out back in November and December and January, don't believe any of it. Sleep apnea is a disqualifying medical condition, but we are not going to ground people while we're trying to get them diagnosed and on treatment. If you got the diagnosis, you will end up needing a special issuance, but that whole process is still being worked out. And so nothing is any different than it has been for the last 15 years, but we're trying to improve our guidance to aviation medical examiners on that. And if anybody's got details that they want, we can talk afterwards. Another big question that has come up, particularly with our docs that are here, is, so when are you abolishing the third-class medical certificate? I heard that's what's going to happen. That's not what's going to happen. All of the stuff that's going on right now is all related to the AOPA and the EAA request for an exemption that the FAA has had since 2012. And it has been a hard thing to answer because it really is asking us to do something that we should have to do rulemaking for. And so what has happened right now, 2 days ago, the administrator actually gave a notice, and you can look it up on the web, we have started a rulemaking project, an expedited rulemaking project, to look at, can we expand the number of people that do not need, within the third class category, that do not need a third class medical certificate. Don't know exactly what it's going to look like. It's going to be out for public comment. That will probably happen in May sometime, early May. All of you here, everybody in the whole public can look at it and make comments, and if you've got opinions about it, I certainly encourage that you do that. But it's not going to abolish the third class medical, but it will essentially expand those people that don't need one, the number of people and the type of aircraft and flying. Coincident with that is there are two bills within Congress, absolutely identical, House Bill 3708, Senate Bill 2103, called the General Aviation Protection Act, which is trying to accomplish the same thing. There, again, if you want to look about what's going on, I encourage you to Google it and look it up. But there are 10 conditions. It's very similar to the petition that came from AOPA and EAA, not exactly, expanded a little bit more. We're hoping to do the rulemaking process and preclude what's being done for Congress. We would like to be part of the crew that's driving the train as opposed to somebody telling us what to do, because we think from a safety point of view that's the better way to do it. So the second is when this rulemaking announcement went out. HIMSS, I'm going to do very, very quickly because I don't have much time. This is what HIMSS stands for. It's the Drug and Alcohol Program within the FAA. If you know anybody that has a problem or you think might have a problem, the way within our system that you work with is you work with a specially trained AME. Not every AME can do it, but a HIMSS AME can. And it's because of what you see right here. It's a disease process like any other disease. It's not a moral problem, it's a disease problem, and it needs treatment. And it's certainly not something that the individual can treat themselves. The original HIMSS concept was for airline pilots, trying to keep them in the cockpit, and that started back in the 70s, and it worked with pilots and the airline management and us as the FAA, but we are using this same process and philosophy for GA now, and having very, very good luck. What we require is what you see up there, diagnosis by, we need a diagnosis, treatment of some kind, either inpatient or outpatient, comprehensive continuing care, monitoring long-term, total abstinence is required. Diagnosis, I say, by somebody that's knowledgeable in the field and understands the FARs, working with a specially trained aviation medical examiner, what we call a HIMSS AME. And what they do is they evaluate the pilot for the quality of their recovery, making sure they're in recovery, and then making a recommendation to us as to whether they should be certificated or not. You can see the success of the program since the 70s. Over 4,500 pilots have received their medical certificate back and are functioning in the cockpit. I got 1 minute left, and if you've got a burning question and want to ask it here, if we don't have time to finish, then I'll be around the rest of the morning, and we'll have no problem answering, face-to-face, one-on-one questions.
What's your question? I'm waiting until we get a mic here, please, Mike.
Okay, out of that 240 fatal accidents, how many were medically related? I mean, versus pilot error versus mechanical.
I can't quote you the number, but I will tell you one thing that is difficult with that is if you look at NTSD data, the NTSD database, the way that they will tag something as causal, an actual cause of the accident, or a contributing factor, their criteria for being able to tag something as a contributing factor or the cause of the accident is very, very limited. It's limited because of what their internal criteria are. It's limited because they can't spend large amounts of time and large amounts of money to investigate an accident to the way, say, that's done within the military. What I was used to is military aircraft accident investigation. If something is very, very obvious on the surface, then it may get tagged as a contributing factor. And so the fact that if you look into the history, are there medical issues that are present? There are numerous ones that have medical issues that are present, but they're not tagged out as a causation or a contributing factor because they don't know. So it's not, I mean, it's negative data, but there is a lot underneath it to say we honestly don't know. I mean, if we look and say, looking at accidents and do autopsy data and how many of these individuals were taking medications that are absolutely unsafe and have side effects that they have no business flying with, and if they looked it up, they would be prohibited from flying with it. Large numbers of pilots have been taking those things. Does it show up in the NTS database that it was a causal factor? No, because we don't know.
I'd like to thank
yeah.
Dr. Berry for the great presentation, and if you have any questions, he's willing
I will be around.
talk to you. And also, please, please, please fill out your evaluation forms. The production crew out there will take them from you. We need those reports. And again, please exit to the right. Thank you, Dr. Berry. Let's give him a round of applause, please. Thank you so much. You did a good job. Want me to help you get that out of your back pocket?